Started right now. My name is Sherry Cisneros. I am the Navigator Program Director for those who don't know me. Welcome to our training. Next slide. CA Bridge is a program of the Public Health Institute's Bridge Center that receives support from the California Department of Healthcare Services. So these are who we belong with. So again, welcome to our CA Bridge training. Next slide. I always go over this and it always makes me so proud of all of the things we've accomplished with our navigators. And our goal is very simple. It's your goal, 24/7 access to substance use navigation and addiction treatment in every California hospital. And without you, our navigators and CHWs, this map would not look like this. So all of it is attributed to all of your hard work. So really hope that you're represented here on our map. Next slide. So just a quick refresh for those who don't know our CA Bridge model. We are revolutionizing the system of care for patients with opioid use disorders, and so many programs have advanced to include other substances. So we're so proud of you guys. It's a three-prong approach, very simple. There's only three things you need to be using our CA Bridge model. The first is what the doctors are doing, and that's prescribing low barrier treatment with buprenorphine, with what some sites, we were just at a collaborative yesterday, are starting methadone. And so we just love the fact that it's low barrier. What is low barrier? Patient comes in and says, I'm in withdrawal. And the doctor just asks when's their last use and prescribes MAT. So that is the ideal situation. And we know so many of your hospitals are doing that. So congratulations. And we love to hear your success stories. And that's low barrier treatment. The next pillar or objective is connection to care and community. That is you guys. You are the resource for our patients to get linked to care. Used to be in the hospital, patients got a list. You are the list. And I love telling that to people who want to hear our bridge story is we don't have a paper list. Our bridge navigators, they connect people because they know who they're connecting to. You guys have great referral resources, and I love to hear that. We're doing in-persons all throughout California with our regional collabs, and you guys have some amazing resource connections, and so I love that. And then the last focus of the CA Bridge model is harm reduction. The culture, you guys are doing it every day in the hospital and out in the community. So we're really proud of you guys. Next slide. We have a few announcements. Our Navigator update for next month. November is already coming, you guys. It's so quick here. It's going to be here soon. Best practices for returning patients. You know, our patients that come back, and guess what, you guys? We're here for them. So we're going to hear some of your guys' best practices and find out what's working out there. Next slide. That's November 12th. And then next month, we will have our Navigator Focus series, and that we will be addressing stigma. And I'm really proud to announce we're going to have two navigators that are teaching this program at their hospitals. So it will be great to see Rebecca Harris and Artenice Walker present that next month, November 20th. Next slide. And then we're still making our way through the state. We're coming down to Los Angeles, November 17th. So if you can come see us in person, we want everybody there. We want this to be our largest. You guys have the opportunity to make this the biggest regional collab yet. We'll be in Los Angeles at the Cal Endowment. And our virtual, if you can't make it and join us in Los Angeles, we will be having a virtual regional collab December 3rd. And if you remember those, if you've been coming quarterly, we break out into your regions. So lots of great networking resources. Come on down. You have two options. So really excited about that. Next. So now I'm going to give all of our time to our new speaker here. She's new to me, new to us. And so please welcome Jennifer Thompson. She's a licensed social worker, and she has been working in community health mental health for the last 7 years in Los Angeles. She's worked in a variety of roles, including a clinician, program manager, director, and supervisor. She's currently, and I was just talking with her about this because I didn't know the acronym that she had here down. Jennifer's working with a full service partnership, FSP, with a multidisciplinary team serving folks on the street and homeless. And I mean, this is just a great full service program that goes to the patients in that do not have a home. So this is great work. I so admire what you do. You take it to the next level. So I'm just really, really excited. We did post up the objectives before I hand that over. And if you are a CEU learner, you will meet those objectives and fill out your evaluation for CEU renewals. So without any more delay, I'm going to hand it over to Jennifer Thompson.
Hello, everyone. Thank you so much for having me. I'm so excited to be here with you today. Thank you for all of the care that you do. It's so exciting to see and learn more about your model and your programs and the work you're doing in the community. So thank you. So I'll start out today. Today, I'm just going to be hoping to go over a little bit about the navigator role, which all of you are in. And so this is just kind of a small discussion point, and then going into co-occurring disorders, different aspects of utilizing different parts of care, and then some tips and things that I think are helpful when navigating our population. So as a navigator, you're likely, a care coordinator at either an emergency room or other community organization to help clients with substance use disorder get connected to services, which can include engaging and assessing the client, linking them to different care, depending on their needs, following up with them if your program allows, because I know that that's not always the case, coordinating with other professionals, providing psychoeducation on different aspects of harm reduction or maybe just whatever issue they're facing, and then using a harm reduction approach. And you utilize all kinds of skills, including motivational interviewing, trauma-informed care, case management, harm reduction, and then knowledge of the different SUD systems and treatment options, and de-escalation if, clients maybe are a little bit more elevated or escalated with you. Next slide, please. So what is a dual diagnosis, or what is also known as a co-occurring disorder? So this happens when, or this is the phrase that we use when clients experience meeting criteria for both a mental health disorder and a substance use disorder. So the most common co-occurrences that you see are mood disorders such as depression, personality disorders such as borderline personality disorder, anxiety disorders, eating disorders, conduct disorders, psychotic disorders such as schizophrenia, and trauma disorders such as PTSD. And the substance use that is often seen in co-occurring disorders are folks who use alcohol, amphetamines, cannabis, hallucinogens, tobacco. So when you're looking at what makes a substance use disorder, what you're going to be looking at is if they meet criterion of which is 11 symptoms across 4 different categories. So impaired control, do they have the ability to control how much and how often they're using? Social impairment, risky use, and pharmacological criteria, so things like withdrawal. So to qualify for a diagnosis, an individual must meet at least 2 of the following criteria within a 12-month period, and then you would rate severity based on how many criterion of the 11 that they're meeting. So 3 to 4 would be mild, I think, and then 4 to 5 or 5 to 6 would be moderate, and then I think more than 6 would be severe. And so it can be something that you're kind of, as you're assessing and engaging the client, asking questions about how often they might be using, what behaviors they engage in around using or to receive, to get substances, how they feel physically, have they ever experienced any kind of impairment or maybe like negative effects related to substance use, like losing relationships or losing jobs, or maybe seeking out substances kind of at the at the cost of other things. The language that you use can be really neutral, although typically, because when you're talking about a disorder or talking about impairment, it can be really like deficit based or the language can be kind of stigmatizing in and of itself. But if you're asking neutral questions with curiosity about, tell me a little bit about, when you started using or how much you're using, how you get it. Does it ever impact you? Do you feel like it helps? Do you feel like it's, causing you issues in any areas? You can gather that information. Okay, next slide. Also, if anyone has any questions or feels like talking or shouting out, please feel free to go in the chat. I am a yapper, so I will yap the whole time if you want me to, but I also would love to hear from everybody else. Um, so please feel free. So, causes and risk factors associated with co-occurring disorders. There are risk factors for both mental health disorders, certain ones, and substance use. So, things like genetic predisposition, certain diagnoses such as depression, anxiety, bipolar, and schizophrenia disorders have genetic components. So, if there is history in the family, clients are more likely or have a higher risk to also be diagnosed. That doesn't mean that it's guaranteed. There's always the combination or the combination of biology and environment. That's a great question. How does it fit into your life? Yeah, I think that's what really helps me um, really view substances in like a really neutral way is that using substances meets some need for the client, right? So what need does it meet? What way does it function in the client's life? Because if their goal is around reducing or changing the way that they're using, um, I'm a big proponent of it's hard to take away something that is serving a purpose or a function if you're not going to use something to replace it. So let's say that it's something that let's say they lost someone and they're drinking because it helps them kind of numb the pain from grief, right? Well, then it's meeting that need of numbing the grief. Not to say that it doesn't have other impacts also. Let's say that they don't like how much money they're spending or it has other impacts that they're not happy about. But we have to be able to address the grief that it is kind of meeting the need of. So, okay, getting grief supports and working on coping skills and distress tolerance to be able to feel those feelings. Environmental factors that increase risk around developing a co-occurring disorder include experiencing trauma, abuse, chronic stress, poverty, chronic illness. If you're experiencing any of these things at a higher level, so you want to look at something like ACEs. For those of you who maybe are not familiar, there was a study called the Adverse Childhood Experiences Study where I forgot what I forgot who did it. I think maybe it was Kaiser. They looked at a really large population, maybe like 20,000 people, and they asked them questions about different childhood experiences they had, including experiencing like sexual abuse, experiencing, witnessing domestic violence, physical abuse, um, things like that. There was, I think, 8 criteria, and the people that had more than four when they looked at their health outcomes, were drastically more likely to have things like cardiovascular disease, substance use, mental health disorders, and things like that. And of course, you can't draw causal, right? Like causal links between that, but it's highly correlated with if you have these environmental factors that you're more likely to develop, things like chronic illness and substance use. And then I just put chicken versus egg because we're not really sure kind of what the link is, right? So folks with mental illnesses are more likely to have substance use disorders, and people with substance use disorders are more likely than folks without to have mental illness. So it's kind of a, which came first situation where they're not really independent of each other. They're very, symbiotic, and to treat one, you generally have to treat the other as like best evidence-based practice. Okay. Go ahead. Okay, so using harm reduction to work with co-occurring disorders. So harm reduction is not about condoning use, right? So it's not about, I think that's sometimes the proponent or something that people who maybe don't understand harm reduction or have like issues with it say is that it's, it's excusing people. The reality is that people are going to use that they're going to use. So you want to promote safety and offering access to safe use and choice. So it's about meeting people where they're at and offering those things. So the core beliefs of harm reduction are everyone deserves, dignity and respect and access to care despite their substance use status. Change is a process. So some things like relapse and things like that are part of the process. It's not an end goal or an event. Any positive change, so using any kind of, less or using safer, staying housed, showing up, accessing medical resources, gaining supports, those are all things that mark success within that framework. And people are experts in their own lives. They know what they're ready for right now. They know what they're willing to do. They know what is accessible to them. And so when talking with clients about things like substance use treatment or whatever, um, you know, behavior or support that they're looking for or are ready for, treat them as the expert and partner with them on a shared goal. So if they want to be safe and we want them to be safe, how do we come together and meet to where both of our goals being met, which is safety? So as a navigator, this means that you help people move towards their goals, not our expectations, right? And we approach clients without judgment or our own agenda. And this may look like clients who are not interested or ready in reducing their use, but they will take safe use kits, things like Narcan, and they will increase their awareness of what community resources are there if they ever change their mind and they want to access that. And so, change can look incremental and it should be client driven and at the accessible to them, right? Okay, go ahead. So some tips continued. People with co-occurring disorders often use substances to self-medicate, and so this can be how they kind of feed into each other, right? And so let's say folks, again, like let's say someone's experiencing grief. So someone might drink to reduce their feelings of grief or to numb out. But because of their alcohol use, maybe they have are having a hard time with relationships with other people, which makes them feel more isolated. So it kind of can feed into each other. And so you want to, check in, where, again, the way Ren said, how does substance fit into your life? What is this kind of, if you are using, like, what does it do for you? They often experience mistrust due to past system harm or stigma. So the more that you're able to start out with like a caveat of like for instance, when I'm meeting with somebody for the first time or assessing them, I always say, I'm going to ask you some questions. You're welcome to share as much or as little with me as you'd like. The more I know, the more I'm able to identify options that I think would be helpful. So you can tell me if you think they're helpful and we can be on the same page about what's going on, right? And so I always offer choice to the client and try to create a safe, non-judgmental space where they can share as much or as little as they're wanting to get their needs met. And that, I'm not the cops. I'm not, I'm not going to judge you if you say that you use, this much of this drug a day or not. It's just helpful for me to know because then I can, link you to the kind of supports and care that you need or that you could need if you're interested. So, and clients with co-occurring disorders often have fragmented care. So they might have mental health on one side with one provider and then be getting substance use with maybe somebody else, or like is maybe because they're not being forthcoming about their use, maybe it's not part of their current like treatment plan with their mental health provider. Current evidence-based practice is to treat them concurrently at the level at which the client will accept. So addressing both the mental health disorder and the substance use disorder with coordination between care teams or on the same care team if possible. Building trust with the client through non-judgmental questions and curiosity. So I think that particularly in settings like if clients are coming in and they may be like irritable or looking for something really specific and you're trying to like gauge kind of how we can support them, I think it can be really easy for clients to feel like we're interrogating them or like we're trying to get particular answers out of them. And so always approaching with like a curious tone and offering, let's say if you're making an observation, offering the opportunity for the client to correct you. So like, correct me if I'm wrong, but it seems like this. I think that that can really open the door for clients to be more engaged and not feel as though we're coming in with any prejudgments or anything like that. Um, Involve the client in all decisions, even the small ones. So asking, what do you feel ready to work on? Or what are you wanting my support with today? And celebrate the small wins, showing up to an appointment, clients coming in for care. That is a win, even if nothing substantial, you know, maybe is coming out of that visit aside from just their continuous coming in, right? So using any kind of less, asking for help, getting housing, making a phone call, those are all wins that reinforce the idea that clients can come in for support no matter kind of what that looks like. Go ahead. So I thought I'd include something about crisis management and de-escalation, just because when folks come in and they are experiencing maybe like a variety of mental health stuff going on, sometimes clients can be escalated. So I thought it'd be helpful. So just as a caveat at the top, if you suspect or a client states that they're at risk of hurting themselves or someone else, or maybe gravely disabled, so unable to care for their shelter, food, clothing due to mental illness, then consult with your supervisor and follow your agency or work protocol. So nothing that I'm saying today should override whatever your oh, thank you so much. Yes, I think that they'll share them with you. That was quite the little ego boost. Thank you so much. I'm gonna keep that for the rest of the day. Um, so if you're so just definitely lean on whatever training or protocol your agency has. There's likely some kind of number that you're able to access to maybe get like a mobile crisis unit or someone on site who is the go-to person if someone needs a risk assessment. So, but if you're working with a client who's escalated, maybe they're shouting, maybe they're really elevated, and you're wanting to engage with them in a way that can help them de-escalate and not need to get to that level, I thought these would be some tips that are helpful because a lot of the clients that I work with present this way, so I get a lot of practice. So first step is regulate yourself first. Don't ever take clients' behavior or anything they say personally. We are often seeing clients at really tough times, if not the worst times of their lives. Even going to the hospital for something like medically relevant is hard, let alone anything related to like mental health or substance use, kind of making that even more complex. So I always try to remember that they're often probably not presenting at their best or being their best self. They're stressed. They're probably feeling physically like crap. And so I'm going to keep that in mind and not take anything they say personally. And use tools to keep yourself calm and regulated. So things like um, maybe like taking a deep breath, having someone like if you need to take a break, if there's someone that can like, okay, I'll get you a glass of water or a bottle of water, I'll be right back if you need to step out and regulate yourself. Maybe create a plan for whoever you're on site with for, hey, like if I'm with the client and they, get really out of pocket and I need to step out to like chill out for a second, what can be the plan there? Um, Adopt a non-threatening stance and a calm tone of voice. So typically the louder that clients get, the quieter and calmer that I get because I'm really trying to model for them how I would like the conversation to go and the way that we can talk to each other. But raising, like if they're shouting back is not going to help anything. Um, Often if people get to a certain point, they're just shouting to defend themselves or to defend their position. They're not listening to anything you have to say. So it's not productive. Use active listening and reflective or empathetic statements. Avoid arguing, correcting, or lecturing. The focus is for the client to feel heard and understood, not to find a fix or a solution immediately. When clients are really elevated, it's typically not helpful to be solution oriented, especially if the solution that they're asking for is not available. It is totally okay to say, like, I hear you, I hear what you want, I get it. I understand how frustrating it must be that you want this and you can't have it. That's so hard. I get it. And even just validating and just being able to sit with them while they ride the wave of their emotions is typically all they need. And then reducing stimulation. So if you're in like a crowded room or a lobby or something, going into a room where there's less people, if there's bright lighting, maybe like a not quite bright lighting, bathroom lighting will set me off at any time. Offering some water, Um, and then offer choices. So, do you want to talk to me in here or over there? Anything you can do to kind of help the client feel empowered and as though you're taking them seriously, even if you're not able to give them what it is they're asking for, but just be a person hearing them and willing to listen to their concerns will often help de-escalate. It's what clients most of the time want is just to be heard. And then remember the tenants, asking open-ended questions. So focus on achieving or maintaining safety or connection. So safety, if that's what the concern is, achieving that, or if the client is really escalated because they wanted this resource or they need this appointment or it's not going fast enough, whatever it is the case may be, just validating and affirming that and being willing to meet them where you can. And then remember the trauma-informed tenets. You want to focus on safety, choice, trust, collaboration, and empowerment. Um, yeah. So if anyone has any more questions about that, I'd be happy to answer. But uh, yeah, thank you. You can go. Okay. So these are some mental health resources for navigators. Now, I did not realize, I think I did, but I just included resources for Los Angeles County, and so because that's where I work. So I really recommend finding similar resources for folks in the area that you serve. So typically, your county Department of Mental Health will have a resource page for a lot of these. They typically should have like a workforce training and education page that has different trainings on different mental health conditions or treatment modalities. Even if you're not a mental health professional, it can be helpful to understand different conditions or things that clients can be going through. So I really recommend exploring whatever county you're in, your Department of Mental Health website and seeing what resources they have. But I'm just going to speak to the ones that are in LA and yeah. So you can call the 24/7 helpline through LAC-DMH. So this is for folks in LA County needing mental health access or referrals. So you can call and say, hey, I need this resource. You can also call 211 and say that I need this resource or this referral for, whatever it is that you're calling about. Find your service area coordinator in LA County. So that PDF that I linked has a list of all the different spas or service areas and who the navigator is, and you're able to reach out to them. It has their phone number and their email. It may say what location they're working at, like if yeah, it may on there. And you can email them about linkage or referrals that you need for a variety of resources. Yes, 988. Thank you so much. Yes. Although um, I do like to use 988 with like a caveat of I think that if there is a I need to get more information. There is a chance that when you call 988 that they may connect you to like emergency services. And so when I do offer that resource to clients, I like to remind them that because to me that's part of harm reduction and trauma informed care. If I'm going to offer you this resource, I'm going to let you know that they may call an ambulance or call the police if there's a risk. That way you can make an informed decision about using them because they may not have that expectation. So, LACDMH has a training section listing workforce trainings that goes over different services. And then under the Department of Public Health, there are trainings for substance use prevention and behavioral health for providers. This link, the Community Clinic Finder, member clinics and affiliates. So if you go there, you can type in your zip code and it shows literally every community clinic in the Los Angeles County. And so you can find whether it's for physical health or behavioral health. They also have a health toolkit linked there that has a bunch of different resources, phone numbers, trainings, things like that related to harm reduction, related to behavioral health. Um, Make referrals based on the level of care needed. So is the person you're talking to, can they go to a community clinic? Are they a person who can make an appointment, keep it, and then follow up to get what they need after? Or do they need a higher level of care? Maybe something like an FSP team or like a field-based team. And so when you're assessing, figuring out kind of what level of care do they need to support to reach whatever goals they are, and then reaching out to maybe your navigate to like the county navigation to say, okay, I'm looking for mental health referrals for someone that maybe needs something like this and seeing what's available. Um, Yeah. And then the Harm Reduction Coalition of Los Angeles has peer and outreach resources, and the LA Community Health Project has syringe access, naloxone, and substance use education. Um, yeah. Okay. So just some tips that I thought would be helpful to include are, so keep a ready list of contacts. So I really recommend, I do this on my team, creating like a guide or seeing if one exists. Um, Actually, let's start there. If there's anyone in this chat that like you notice that is at like a hospital or a site that's near you geographically, I recommend reaching out and saying, "Hey, I'm a navigator near you. What resources do you have? Let's pool together and figuring out like where are they referring people? What resources are they using? What has been helpful? What has been tricky? What are the barriers?" Um, and then keeping a guide that you can reference. So helpline numbers, your service area navigator team contacts, local clinics, peer support groups, so you can quickly lead clients. Also, if you notice, especially if you're in like an emergency room setting, that there are clients that are coming in or patients that are coming in that maybe are linked to local like nonprofits or like different community clinics. You can try reaching out and forming a relationship with them and saying, hey, I'm a navigator here. There may be clients that are well known by our providers that you can build that relationship with. So when there does need to be linkage and referral, you have somebody that you know. I think that particularly within our line of work in behavioral health, like who you know is everybody, right? So the difference between getting somebody into treatment and even being able to get a hold sometimes of like different treatment facilities, like having someone on the inside that you know, like, hey, I can email this person, they will actually respond to me. I maybe have luck of getting this person into treatment today because they're interested. Build those contacts. Um, so this can be helpful in coordination. Understand which service area your work covers. So LA County divides into service areas 1 through 8. So I work in service area 5, and so I am pretty familiar with the areas of 5. So the local navigator teams differ by different areas, and this could be specific to whatever county you're in and whatever state you're in. Um, Utilize the training opportunities listed, even if you're not a clinician. Understanding the basics is really helpful because then it can be a little bit easier to engage and build rapport and have empathy for maybe really challenging behaviors you might see due to behavioral health. Um, I recommend using peer and community support organizations like NAMI. So they have really great education on their website, and they also have like peer support groups for, I think, substance use and wait, I might be lying about substance use. They definitely have it for different behavioral health stuff. So like people living with schizophrenia, people living with depression, if they're looking for peer supports, they're a really good resource. And then also just having an emergency escalation plan for life-threatening emergencies. So figure out what the plan is for your site and have resources on hand. So if a client comes in and they're telling me they're going to kill themselves, what is the go plan? If a client comes in and they're really escalated, what is the go plan? And making sure that you feel comfortable and familiar with the protocol and that your site has one, or for whatever reason, if you're in maybe like a less supportive environment where like you're more independent, having an idea of what community resources that you can rely on should you need to in that time. Yeah. Oh, see, I knew I wasn't making that up. Thank you, Latoya. Yes. Okay, substance use groups too. Go ahead. Oh. So this is relevant just to California, but I thought it would be a really interesting thing to include. So in January 2026, SB 43 goes into effect in California. So this Senate bill expands the definition of grave disability for the Lantern and Petrus Act in California, which means that starting in January, people can be placed on grave disability psychiatric holds if so grave disability is being expanded to include um, personal safety or necessary medical care as one of the criteria due to a substance use disorder. So prior to January 2026, it just says inability to provide for one's basic personal needs, including food, shelter, clothing, due to mental illness. So if there's someone who may be gravely disabled, so unable to care for themselves, but it is due solely to a substance use disorder, up until this point, they are not able to get maybe like a higher level of care if they need it. And this has been something challenging that people experience in community mental health. Obviously, the goal is always to treat folks in the least restrictive environment and to keep people in the community getting care if they can. But there are people that I think do need a higher level of care and support, and that has not been able to happen up to this point. But in January, that's being expanded. So what that means is that in January, there may be an influx of psychiatric visits to the emergency room or people who are seeking like substance use referrals because they have been hospitalized and part of their discharge plan is getting linked to substance use facilities or programs or things like that. Um, so I think that there's probably going to be an influx into ERs in January. And so there may be a shortage of placements if the number of people being held increase in demand for placements in psychiatric hospitals or treatment centers. And so I really recommend like just keeping that in mind and I guess seeing if there's any kind of preparation or change at your facility or anything like that. I don't think there's been a ton of infrastructure increase at all to reflect on this change happening. Um, so I think things could get a little bit hectic, but I thought it would be something to discuss during the training so that it can be something that you're aware of that's coming in the next 2 months. And yeah, Hearing Voices Network has good peer-based group of folks. Oh, thank you. That's a good resource. Thank you. Um, okay. And
So,
then
oh,
go ahead.
sorry. Thank you, Jennifer. So I'm curious. We do have a little bit of time, and I really want to make good use of some of our time. What questions are coming up for the audience that since we have such a subject matter expert, what subjects or sorry, what questions are coming up for you that you would like to ask Jennifer? And you can feel free to put them in the chat. I'll read them out, but would love to hear it. One question I'm going to go ahead and ask, one question that I've heard fairly recently, or maybe a statement, not so much a question, but when working with people who have a diagnosis of or are maybe presenting with some sort of schizophrenia or like, hearing things or seeing things that other people don't, you should never be closed in a room with them. Always maybe they require a higher level of care, and so that may not be a good time to complete any kind of screening or assessment with them. How would you respond to that?
Yeah, I think that's a really prevalent, a relevant topic. So I think that for folks that maybe don't have experience working with folks with psychotic disorders, it can be something that may seem intimidating, right? Because we don't really know what to expect. And I think also that like media does a lot of incredible work at presenting folks with psychotic disorders as like scary or risky. The majority of people with disorders like schizophrenia are at higher risk of being victimized, rather than like victimizing others, or are more likely to like be a harm to themselves than other people. So that being said, if they present at the emergency room or in some other placement, they might be really symptomatic or really elevated and maybe asking for things that maybe don't make sense to us or that are not attainable. And so my tips and tricks for working with someone who's like really actively experiencing psychosis is to um, to use this acronym that was created by this psychiatrist named Dr. Xavier Amador. So he wrote this book called I'm Not Sick, I Don't Need Help. I really recommend it. He's a psychiatrist whose brother had schizophrenia. I'll put it in the chat. And he wrote a book about how to partner with people, in particular with schizophrenia or substance use disorder, who are treatment resistant, who don't understand why you would want them to go on medication, because I think something that people don't necessarily know about schizophrenia is that one of the key symptoms is anosognosia, which is a lack of insight into symptoms. So people with schizophrenia and other psychotic disorders do not have insight into their symptoms. They to themselves seem completely normal. They don't understand what people are talking about. This is totally what everyone else is doing. And it's not because they're being difficult or because they're being treatment resistant. It's the same way that I would try to convince you that I'm not talking to you right now. You would tell me that I'm crazy. Of course, you're talking to me right now. Everyone else can see you. So we have to remember that it's very real for them. It can be very distressing for them, but that's not always the case. And so the book that Dr. Amador wrote uses an acronym that he wrote called LEAP, which is, I'll put it in the chat, LEAP. So listen, empathize, accept, partner. So without trying to, like, with absolutely no agenda, just listen to what they have to say. Empathize with whatever their grievance is, if they have one when they're coming into this setting. Accept what they have to say. And by accepting it, I'm not saying that you have to agree with it or endorse it. I think that's a really key thing, is that I can accept and validate the distress that you are experiencing as a result of what you are talking about. Your fear, your anger, your distress, your concern for your safety because of some persecutory stuff maybe, is that that must be so hard. I hear you. That doesn't mean I'm saying I agree that the government's after you and that, there's cameras in the TV. I'm not saying that, but like, that sounds so scary. I hear how concerned you are. How can we partner together to help you feel safe? And that's the P stands for, partner. What is your goal? What is their goal? And how can we partner together to achieve that goal together? And so, thank you. Yeah, LEAP. So he goes over how to do that in the book. There's also tons of resources online because it's kind of it's a thing people talk about, but it's really effective for folks with psychotic disorders and also folks with substance disorders. And the book is not written in clinical terms. It's written for loved ones of people with those disorders who want to understand more about what their loved one is going through and how they can engage with them in a way that is meaningful and kind of, respects what's going on with everybody. So I really recommend that book. That being said, yeah, I mean, if folks come in and they're really elevated, they're symptomatic, they're seeking whatever it is they're seeking, listen, empathize, accept what they have to say, partner on what you can. So like, I hear you, you want to be safe. What is needed for you to feel safe? This is what I can offer. This is what I can't. I understand if that's frustrating. Let's meet somewhere in the middle. So I think, yeah. Also, if someone is experiencing like a delusion, it is never productive ever to try to convince them that what they're experiencing is not real. It will just drive a wedge further between you and them feeling misunderstood and like nobody gets it. And so that can be a deterrent to seeking out treatment. So I think you can always approach with curiosity. Tell me about what you're experiencing, and then empathizing. That sounds, frustrating, sad. It must be scary. Tell me more about that. So being curious, asking questions from a truly curious standpoint, allowing yourself to be corrected if what you're saying is not reflecting what their experience is. So I like to, again, say, like, correct me if I'm wrong, but that sounds like that could be really scary. And then they can say, no, actually, I kind of find it, confusing. Thank you. That makes total sense that that would be confusing. How can I, what are you looking for my help with today? And then partnering from there. And if they're in a place where they're really elevated and they're just not able to maybe meet you kind of where you're at with, like, in terms of linking or referring or things like that. Absolutely. Absolutely, Ren. Yeah. That's a really good metaphor. You don't have to feel the pain or be able to see what's going on to be able to understand that the person that you're talking to is experiencing it, and needs support and empathy, even if maybe they're presenting in a difficult way. Yeah, so those are all my little tips and tricks for engaging with someone who may be experiencing psychotic disorder, or something that kind of makes it so that maybe like trying to complete an assessment or do a referral linkage is not the most productive use of time in that session, and just building that relationship and listening to them and being a person that they can talk to is. I can send one out. I can send one to Bridge. I can look through the different trainings I have bookmarked and send it. So, that's a really good question.
I
Yeah.
have one too, Jennifer, because thank you for mentioning that. And, somebody, especially in our navigators in the emergency room, and these patients are really struggling, and, the navigators see the nurses and doctors giving medicine, and restraints, and have sitters. So that's all a normal part, but I just love building a trusting relationship. It might just be walking in the room and saying hello and introducing yourself. Um,
Absolutely. Yeah.
yeah, so I love your tips and strategies. The one thing is our navigators deal a lot with substance use, and that's causing the psychosis. With
Yeah.
like methamphetamine and other drugs. What do you suggest? When they are in those psychosis? I mean, it would be the same, but I just want to make people aware. Is this psychosis going to leave when the methamphetamine runs out?
It might. So if the let's so there's a lot of stuff that could be going on. It could be like if you're seeing them in like acute care, like they just came into the emergency room, they could be experiencing some kind of independent psychotic disorder, or they could be experiencing something medical, so you always want, before assuming that something is a mental health disorder, you also want to make sure that it's not due to substance use or to a medical condition, because there are things like, I think, like sepsis and things like that that can cause um, mental health symptoms. So you always want to rule those out, right? But when they come in and they're in acute care, you're not really sure, right? But like, let's say that you're working with someone who's been hospitalized for a couple weeks and they're not getting access to any substances and they're still experiencing psychotic disorders. They may have a pre-existing psychotic disorder illness, or they may have like a substance-induced psychotic illness. The etiology is not really necessarily as important as like they all kind of benefit from the same like non-judgmental listening, rapport building approach where you partner, empathize, and try to partner on the things that they're most things that the client wants can be tied back to like choice, safety, independence. And so it doesn't have to be like, I have a client right now who his goal is to get us to leave him alone. He would love if we would quit messing with him, because we come visit him really frequently because he's really, really at risk. And so there are things that he can engage in that would make him a little bit less risky. And his motivation to do those things is because he wants me to quit bothering him. He's tired of my face, of me coming to visit him at his apartment. Um, I try to be a lovely visitor, but he, wants to do his own thing. And so that's what I'm saying. Like, we can partner, and like, I don't make him see me. He doesn't have to open the door, but like, he wants independence, to be left alone. I want him to be safe. We partner in all of those things by changing some of the things he has going on that just help him access safety a little bit easier. Um, so, and when it comes down to it, all of our folks are, adults with autonomy. We all want our personhood to be respected and seen. And there are ways to see that and acknowledge it. And everybody, even the folks that maybe are a little bit more interpersonally difficult or maybe presenting in a way that we just don't understand, it serves some function.
Thank you. I love that. The fact that, sometimes they don't want to see us anymore. So they'll do, whatever they can to be on their way. So thank you again with your tips and
Yeah.
yeah. Anybody else? I know anybody else with a question? This is
I'm
your
loving all the movement in the chat, by the way. I agree with everything. Yes.
absolutely.
Yeah, one of the things, and just kind of calling out, you touched on Jennifer, on other trainings that you have bookmarked. And I think that that's a really fantastic way to kind of stay current and remind yourself of what resources are available. We also have trainings where we've covered kind of motivational interviewing and having that active listening. But I love what you said about about LEAP and really making it a partnership. That's so fantastic. And it seems doable, especially when you do have some of those, people who are presenting with methamphetamine use and kind of seem like they might be a little experiencing some delusions or whatever else. It makes sense that you can utilize LEAP to still engage with them. So
Absolutely. Yeah.
I appreciate that. Um, any other questions? We still have a few minutes left. You are welcome to ask your questions in the chat.
Oh. Shout out Henry.
Oh, Let's Recover. Yep, we love Let's Recover. And well, actually, we touched on it a little bit earlier in your introduction, but I was hoping you could give us, Jennifer, a little bit more details about what it is that you do at the People Concern and how maybe some of our local LA County folks can collaborate and partner with you.
Sure. So I'm a clinical supervisor with our FSP team on the west side at the People Concern. So the People Concern is an agency that serves folks experiencing homelessness and offering mental health, case management, housing, linkage and navigation, all kinds of services. So my team is based out of SPA 5. And so we have a team of clinicians, case managers, and a substance use counselor that has caseloads of folks that we go out to provide intensive case management and therapy to, like at where they're at, whether it's an encampment or in a shelter or in an apartment if they're independently housed. We also have psychiatrists on our team that go out and do street psychiatry, and we partner with a local clinic and have a physician's assistant that goes out with us weekly and does street medicine so that there's really low barrier uh, access to care to get things like primary care and things like that. So my role on the team is a clinical supervisor. So I provide clinical supervision for all of the pre-licensed clinicians that are on the team that are counting their hours. They practice under my license. I also run a couple of groups, like just supervision groups for the agency. And then I do all of our teams. Well, not all of it. I do my other primary role is crisis management. So when clients need to be assessed for danger to self or danger to others or grave disability, I go out and assess and then write the LPS application for the hold and hospitalize them. So I do a lot of crisis management and I guess diversion, trying to treat folks in the community and keep them safe where they're at.
That's wonderful. And so, I mean, I used to be a navigator years back. And so hearing all of what you do and what the People Concern offer makes me think about this SB 43 and how finding contacts such as yourself and organizations similar to what you're doing would be beneficial for me when I'm connecting patients to higher levels of care,
Sure.
especially for our unhoused folks who are usually using methamphetamines and or other substances. And you're offering street medicine, you offer therapy wherever they're at, which is phenomenal. So that would be a great resource to be able to connect people to so that they can get, multiple levels of care that they need.
So it's not just my team that provides this. So there are FSP teams all over the county. And so if you want to refer a client, you refer based on the spa in which they live. So if you go, you could Google even like LA County DMH FSP application. And then there are instructions for who to fax it to based on what spa you're in. So we're one of the SPA 5 providers. We're not the only one. So if you're in SPA 6 or SPA 4, you might work with like Exodus or St. Joseph's or something, right? We have a Skid Row team as well. So you would submit an FSP referral and then they would get linked to a team. Depending on the spa, there might be a small wait list. And so that's why really you want to assess what level of care do they need. If they're experiencing like street homelessness, I recommend getting them to like an access center to begin, like if they're interested. I think that's the other part, is that not everybody who's currently experiencing street homelessness wants to like be linked to a shelter. Like shelters have a lot of things about them that can make it hard. You have a certain amount of belongings. You can't take pets. If you have a partner, they might, you may not be able to go with them. And so I think just depending on what resource the client wants, but if they're interested in getting linked to housing, sending them to an access center so that they can get started on like getting a case manager and access to housing navigation. And then they can also, I think, link to mental health teams typically that will work like within their spa. But if you're seeing folks that are maybe like you're familiar with, because you've seen them more than once, and you're able to kind of ask questions about any services they're engaging with, and then maybe link with them, that could be helpful. But yeah, FSP referrals, maybe for folks that are like experiencing street homelessness, severe persistent mental illness, chronic illness, substance disorders, all of the above, like high risk folks. Yeah, they're all over the county. So, and if anyone has any questions also for like LA County services or specific stuff, I'm happy to put my email. Please email me. If I do not respond in a day or two, you ended up in my spam, and I'm so sorry. Please bother me again. And I check my spam every couple days because I'm notorious for this. Um, but I'm happy to help link if I can. And also just happy to say hi. I'm a yapper. Again, as you can all tell, you've been my hostage for the last hour.
Awesome. Thank you so much, Jennifer. I really appreciate it, and really great information that you've covered today. And also thank you for including your contact information. I'm going to go ahead and get us back over to the slides to tie everything up. Here's our knowledge check. And as a reminder, you will receive all of these slides in a post-event email, including the wonderful content that Jennifer has provided today and this knowledge check. So test your knowledge and go through it and see how you do. We have a plethora of resources for you per usual on our website. Go ahead and take out your cell phone or do a screen grab, whatever's easiest, and scan this QR code so that you have access to our resources. We have a ton of training available for you that can also provide CEU for those registered as SUD counselors, peer support, and for our CHWs. So feel free to peruse through our CA Bridge Academy. We also have training available for CEs for nurses and CME for physicians. So great content to share out. And then we would love to hear from you. So aside from a survey that you'll receive, we also want you to contact us. Let us know what other questions you have, what other content that you want to see from us. And here are more of your Bridge Navigator team mentors, myself and Chaya, and our wonderful director of the Navigator program. Sherry oversees all of this training and helps us put together really great stuff for you. So we appreciate all of you being here and making the time to learn and better be able to provide services to the people that you see. Don't forget to check out our resources and follow us on LinkedIn. And have a great rest of your Thursday. Bye.
Thank you, Betty. Bye.